All right, today we are going to do a high-yield, no-fluff review of malaria. This is everything you, as a busy medical trainee, really need to know when you're faced with this at the bedside. We're going to cut right to the chase and focus on how to manage this disease, because it can be an absolute killer.
So, let's just jump right into a classic case. Picture this. You're in the ER, this patient walks in, and they just feel totally wiped out. Fever, headache, the whole deal. And they tell you they just flew back from sub-Saharan Africa. That travel history, that should be setting off alarm bells in your head. So what's the first thing you're thinking of?
If malaria was your answer, you are absolutely right. And this isn't just some factoid for an exam, this is a clinical rule to live by. Anytime you have a patient with a fever who has been to a place where malaria is common, you have to assume it's malaria until you can prove it's not. It has to be number one on your list.
So here's our game plan. We're going to walk through this just like you would in the clinic. We'll start with how the patient looks, then figure out which bug we're dealing with, and nail down the diagnosis. After that, we'll cover how to prevent it in the first place, and of course, how to treat it. Then we'll wrap it all up with the key things you just got to remember.
Okay, let's get back to our patient. What does malaria actually look like when someone first gets sick? The tricky part is, it can look like a whole lot of other things, because those early symptoms are super nonspecific. First off, that incubation period is huge. It can be as short as a week or as long as 3 months, so you need to ask about travel way back. The classic triad is fever, headache, and muscle aches. Sounds a lot like the flu, right? And you can get GI symptoms too. The crucial takeaway here is that these generic symptoms, plus a travel history, should make your malaria sense tingle.
Now this is a term you absolutely need to know: hyperparasitemia. This is what separates a pretty standard illness from a full-blown catastrophe. When the lab calls you and says that 5 or even 10% of the patient's red blood cells are infected, well, that's a 5-alarm fire. You are officially in a medical emergency.
And that massive parasite load usually points to 2 main culprits. Out of all the species of Plasmodium, there are 2 you really need to worry about: Falciparum and Nulci. These are the ones that can kill your patient, and quickly. This is why figuring out the exact species isn't just an academic exercise. It literally changes how you manage the patient, second by second.
So we know who the bad guys are. The next critical step is figuring out how to tell them apart, because that's going to dictate our entire plan of attack.
This table really simplifies things down to the 2 big questions you need to answer. First, is this thing going to kill my patient right now? That points you to Falciparum and Nulci. Second question, can this thing come back and cause problems later? That's where you think about Vivax and Ovali, because they have these sneaky dormant stages in the liver that can cause relapses months or even years down the line.
Let's really hammer this home by comparing the big players, Falciparum and Vivax. Think of Falciparum as a bomb. It's an acute, life-threatening emergency with a high parasite load. It's happening right now. Vivax, on the other hand, is more like a boomerang. It's usually less severe at first, but it has that nasty risk of coming back. And you need a totally different treatment plan to stop that from happening.
Okay, so your clinical suspicion is through the roof. You know what you're worried about, so how do you actually prove it? How do you get that definitive diagnosis?
Here's your toolkit, but let's be clear. The undisputed #1 gold standard is the peripheral blood smear. A good lab tech can look under the microscope and tell you everything. If parasites are there, which species it is, and what the parasite density is. Now, those rapid tests are handy for a quick answer, but, and this is a huge but, they can be falsely negative. They are never, ever a substitute for a smear. You always need the smear to be sure.
All right, let's pivot for a minute. Instead of just treating malaria, let's talk about how to stop people from getting it in the first place. This is a huge part of travel medicine.
Choosing the right prophylaxis isn't a random choice. It's a system. First, where's the patient going? That tells you about the local drug resistance. Second, who is the patient? Are they pregnant? Do they have G6PD deficiency? That'll rule out some drugs. Only then do you pick the right regimen. And finally, and this is so important, you have to counsel them on exactly when to start it, how to take it, and when to stop.
This shows your main options from most of the world now, which has chloroquine-resistant Falciparum, and check out the different schedules. Atovaquone/Proguanil is super popular because it's a short course. Start a day or 2 before you go, stop a week after you're back. But look at doxycycline and mefloquine. You have to keep taking those for 4 full weeks after you get home. People always forget this part, so you have to really emphasize it.
Okay, back to our sick patient. The prophylaxis either failed or they never took it. We've got a confirmed infection. Now it's time to treat it.
This is a massive fork in the road in terms of treatment. Is it uncomplicated or is it severe? For uncomplicated falciparum, we're talking oral meds like artemether lumefantrine. But for severe malaria, we're talking high parasitemia, confusion, organ failure. You do not mess around. The treatment is IV artesunate and it's started immediately. This is non-negotiable and it's what saves lives.
And here is a clinical pearl you cannot afford to forget. If you diagnose your patient with P. vivax or P. ovale, your job is not done once you treat the infection in their blood. You must add a second drug, either primaquine or tafenoquine, to kill a dormant parasites hiding in the liver. If you forget this step, your patient will relapse. It's a guarantee.
But hold on. Before you even think about prescribing one of those drugs, you have to stop and do 2 critical safety checks. These are absolute contraindications. First, you have to test for G6PD deficiency because these drugs can cause massive, life-threatening hemolysis. Second, you have to make sure the patient is not pregnant. Never, ever forget these 2 things.
So, we have covered a ton of ground here. Let's just boil it all down into the most important, high-yield points that you need to carry with you on the wards.
Look, if you remember nothing else, remember this. Fever in a returning traveler is malaria until you prove it isn't. High parasite count should make you think and worry about falciparum. Falciparum and Malaceae are emergencies. Your gold standard for diagnosis is the blood smear. And finally, all of your decisions about prevention and treatment depend on geography and local drug resistance.
And we'll end on this. Your patient is all better and you're discharging them. What is the single most important piece of advice you can give them for next time that doesn't involve a prescription? It's simple, right? An ounce of prevention. Remind them to use DEET insect propellant, sleep under an insecticide-treated bed net, and stay inside between dusk and dawn. Because the absolute best way to treat malaria is to never get it in the first place.